Hello, I'm Kathy Mathews. I'm from the University of Iowa Carver College of Medicine, and I'm going to be continuing a talk on the dystroglycanopathies. So in the first mini lecture of this two-part series, we talked about what the dystroglycanopathies are. They're a group of muscular dystrophies that are characterized by hypoglycosylation of alpha-dystroglycan. That hypoglycosylation disrupts the linkage between the extracellular matrix and dystrophin intracellularly. And as a result, patients get muscular dystrophy, and they may or may not have abnormalities of eye and brain development. So one of the things that we talk to medical students about is that you should always learn something from every patient. So what I'm going to do in this series of slides is go through several patients that are my patients and try to introduce you to the range of the clinical phenotypes with this group of disorders, and also give you teaching points that we can take from each patient. What have they taught us? So the first patient is one that I took care of many years ago now. He was known prior to delivery to have an abnormality of brain formation by a prenatal ultrasound. When he was born, he was profoundly hypotonic and weak, and he remained hypotonic and weak throughout his life. You can see that in this professional picture, he is propped up. He's not able to sit by himself. He's propped up on a chair. You can see that he has a feeding tube going out of his nose, so he wasn't able to feed orally and was fed through that tube. And you can't tell necessarily by the picture, but he's blind. His optic nerves didn't develop. And he also has glaucoma. He was suspected of having a muscular dystrophy and had his CK checked at 3 weeks, and it was 2,000, whereas normal is less than 200. And the CK, again, reflects a leaky muscle membrane. He started to develop seizures at 1 month, and he died before age 2. So this is an MRI of a patient with Walker-Warburg syndrome, and the patient I described has a classic presentation for Walker-Warburg syndrome. So Walker-Warburg syndrome is the most severely affected form of dystroglycanopathy. So on the right is a normal MRI in a healthy control patient. And just to orient you, this is a midline slice, and then the brain is opened up, so you're looking at the midline. This is the tongue. Over here is the nose. The eyes would be over here, but they're outside of the frame of the picture. This is the spine, and here's the spinal cord. This is the brain stem. This is the cerebellum, and this is the cortex. So this is the normal brain, and then over here you can see a number of abnormalities on the brain MRI of a patient with Walker-Warburg syndrome. You can see, first of all, that the brain is very smooth. There are no gyri. This is called lissencephaly and is typical of Walker-Warburg syndrome. We'll talk about, it's called Cobblestone lissencephaly, and is related to an abnormality of brain development. I'll show you a little more about that in a minute. There's massive hydrocephalus, so all of this is just a fluid-filled space. You can see that the brainstem here is too flat. You don't have, over here you have a protrusion that is the pons. You have no such protrusion over here. The cerebellum is virtually absent or almost absent. And then you have this characteristic kinking of the brainstem, and that is very typical of patients with Walker-Warburg syndrome. So the MRI gives you a strong idea of what syndrome you're dealing with, and that this is a dystroglycanopathy. So I mentioned that the lissencephaly is called Cobblestone lissencephaly. In this image taken from a publication, a review publication, when the brain develops, the neuron, which is shown in the normal case on the left here in green, is sort of climbing up a glial fiber toward the outside of the brain. And you can see there in purple that there's a little mushroom-shaped guy that is dystroglycan, and just like in muscle, it's attached to the extracellular matrix or laminin, laminin, and that dystroglycan has to be heavily glycosylated to make that attachment. If you don't make that attachment, then the membrane at the outside of the developing brain breaks down, just like the muscle membrane breaks down. And that little neuron climbing up the glial cell doesn't know to stop because that membrane's not there. And so he keeps climbing up and ends up outside of the membrane. And what that does is result in a disorganization of the cortex and a smoothing of the cortical ribbon. So in a mouse, on the left is a normal mouse brain that you can see the nice layers. You can see that there's sort of a pale layer on the outside and then a denser layer where the neurons are. And on the right, you see that that layering has been completely disrupted. So that is part of the reason that you get these profound brain, developmental brain abnormalities in children with Walker-Warburg syndrome. So from this patient with Walker-Warburg syndrome, we see that muscle, eye, and brain abnormalities due to abnormal glycosylation can be quite severe. That brain malformation is quite severe and not compatible with long-term survival. These brain and eye abnormalities occur during development. So muscular dystrophies are progressive disorders. There's progressive weakness. The brain and the eye abnormalities occur during development, and we have no evidence right now that they are in any way progressive. What you have is what you're born with is what you have. So our next case is a 10-year-old boy, Korean boy. He was 10 when I met him. He had been hypotonic from the time of birth. He sat alone at 11 months. For those of you who don't remember your little brothers and sisters or haven't done child care, normally children sit around 6 months. He was never able to walk. At age 10, he used about 100 single words. So clearly we're in a more benign, a milder disorder than the first child I presented. He had a muscle biopsy that was done in infancy that we didn't have and was reported to show a muscular dystrophy. At 5 years of age, he had a CK that was 8,000, again, quite elevated. And he had a repeat biopsy done when he was 5 that just showed end-stage muscle. There was no muscle there. There was no testing to be done. And we also weren't able to get more muscle from him. So we were left in a quandary for how do we go about diagnosing this patient. So one of the first of all, before doing that, I just wanted, I've been talking about a hypotonic infant. So one of the ways that you check for hypotonia in an infant is you lie the child down on the table and then you pull them to sit. And as you can see in this image, this child has head lag, so he's not able to pull his head up off the table. And he's also not helping with his arms. He's not doing this to help pull you up to sit. So he's just flopping. So that's when we talk about hypotonia and head lag and weakness in an infant, this is what we're talking about. So this child, as I was trying to come up with a way to make a diagnosis, I again did an MRI. And in this case, what we see are cerebellar cysts. So in this case, these two images are just different ways of setting the MRI machine to look at the same thing. So it's whether you want to see the cysts as white or dark. On the left, white is fluid. On the right, the fluid is dark. And you can see in the cerebellum, which is what the arrows are pointing to, that there are cystic holes. There are little tiny holes throughout the cerebellum. And these are very typical findings in patients with certain kinds of dystroglycanopathies. So with the information that I have a child with muscular dystrophy who has cerebellar cysts, and the muscular dystrophy appears to be a membrane-related muscular dystrophy with highly elevated CK, it puts me into a dystroglycanopathy category. Now in this particular case, I looked very hard. I mentioned that this family was from Korea. It turns out that this child was homozygous for a Japanese founder mutation, so it's a specific mutation that you don't find with routine sequencing. And the probability of a homozygous child, which is what he was from Korea, I calculated at the time to be 1 in 3.5 million. But the teaching point here is that the cerebellar cysts in this case were a very strong clue to me that I should be looking for a dystroglycanopathy. So certain patterns in brain development can suggest a diagnosis. Our next case is now a 13-year-old female, and she did well initially after birth, but she started having seizures at 3 months of age. And when she was examined by a neurologist at 8 months, she was profoundly hypotonic with poor head control. Frog leg position just means that her knees flopped out, just more hypotonia and floppy. She was non-weight bearing, so if you lifted her up, most children at 8 months will bounce and jump on your knees. She wouldn't bear weight, she would just collapse down. When she was 4 years old, she was able to crawl and had improved sitting control. And her seizures were adequately controlled on 3 medicines. That means she had a pretty bad seizure disorder. We don't like to have children on 3 different medicines. At this point, we had assumed that her whole developmental problem was because of whatever went wrong with her brain that caused the seizures, and we weren't thinking about any other kind of muscle problem. However, when she was 4.5 years old, she had a viral illness that resulted in loss of crawling, poor head control, and worse sitting. So she just lost developmental milestones from a motor's perspective, although the rest of her health had returned to normal after this mild viral illness. So that loss of skills prompted checking a CK, which was moderately elevated, and it was repeated, again elevated, and then repeated again, and now it was actually rather high. So this was our first clue that this child might have some form of muscle disease in addition to her seizures. At 10 years of age, she had spinal fusion for scoliosis, or curvature of the spine, which is very common in individuals with various kinds of muscle weakness. And at 13, she has rare seizures. The seizures are better controlled. She is not able to speak, but she does communicate well with her parents and with caregivers. She understands some language. She's able to eat some by mouth, but she has a feeding tube in her stomach, not through her nose, but directly into her stomach, a gastrostomy tube to supplement her feeding, and she's not weight-bearing. So in this case, we again did an MRI, and she has a small brain, so the whole brain is small for her face and body. Her cerebellum, which is shown here on the left with the white arrow pointing at it, is smaller than it should be. It should fill most of that space back there. And then she has a very subtle abnormality of the cortex, so much less dramatic than the first child I showed you, but there is a subtle abnormality with thickening of the cortex. It should be a very thin ribbon of cortex. In this case, it's thickened and a little bit smoother than you would expect it to be. So she has subtle abnormalities of the brain. And we did a muscle biopsy. And on the left, you can see the H&E, and it shows a mild to moderately dystrophic picture. And then we do a series of immunostaining to try to narrow down what kind of muscular dystrophy it is. So in this image across the top is control muscle. The first column is a stain for glycosylated alpha-dystroglycan, so it doesn't, you have to have sugar groups in order for it to stain normally. The middle column that is 6A41 is a different antibody for glycosylated alpha-dystroglycan, so it's often more sensitive to hypoglycosylation. And then the final column on the right is beta-dystroglycan, which is used as a control. So that tells you that beta-dystroglycan is, and you can see in all cases, is there and stains normally. The 2 bottom rows are both from the patient that I'm presenting. And you can see that the first column, 2H6, there is some patchy decreased staining, and this is what we typically see with a disorder of glycosylation. And the 6A41, or middle column, there's more impressive decreased glycosylation. So the muscle biopsy led us to think that this was probably a dystroglycanopathy. Steve Moore's lab went ahead and did Western blots. So I think you're familiar with some other Western blots. In this case, we're looking at the glycosylation of alpha-dystroglycan. The columns from left to right, there's a ladder and then the control patient. And you can see at around the 250 range, there's a smear of normal glycosylated alpha-dystroglycan. So there is a range, a normal range of the amount of sugar on alpha-dystroglycan, and so you see that smear. From P1 through P9 are patients with suspected or known alpha-dystroglycanopathies. And the red arrow shows our patient. And you can see that in each of these cases, there's very little in the row with normal glycosylated alpha-dystroglycan, but just under that, there is a very strong band at a hypoglycosylated alpha-dystroglycan level. So this provides further evidence that we are dealing with a dystroglycanopathy in this case. And in this case, genetic sequencing revealed heterozygous mutations in the gene called GMPPB, which confirmed the diagnosis. Learning points from this case: the muscle biopsy can be extremely helpful in demonstrating abnormal glycosylation of alpha-dystroglycan, and Western blot can also be used. And you should consider alpha-dystroglycanopathy in a child with abnormal brain development. In this case, I didn't consider it for the first 5 years of her life. It wasn't until she had that viral illness and became weak that I considered it. And we'll come back to that point in a few minutes too. Okay, so the next case is these 3-year-old twin girls. And this is them at their first ballet class, and the mother sent it to me, and it's too cute not to include in almost every talk I do. These girls were normal at birth, not surprising. They look pretty darn normal there. They were a little bit late walking, but nobody was worried about it because there was a family history of late walking. When these girls were about 2.5 years old, they both had viral illnesses. Sound familiar? The viral illnesses were nonspecific. They had a low-grade fever. Crud lasted about 5 days, but 2 days after the illness resolved, they were both hospitalized and in the intensive care unit for profound weakness. And they were in the intensive care unit because the clinicians caring for them were concerned that they would not be able to support their own breathing. CK levels in both of them were greater than 20,000, and both of them recovered well over about 1 week. So the diagnosis at that point was unclear, and the clinicians caring for them thought they might have a metabolic myopathy. If you remember the Venn diagram in the original mini-series, that there are metabolic myopathies that can present similarly to this. In this case, however, as they checked, the girls were back to normal, but the CK, as they checked it 1 month and 2 months and 3 months later, remained quite elevated in the 2,000 to 4,000 range. So that suggested that this was in fact a muscular dystrophy and not a metabolic myopathy. Because of this history being rather typical, we started in this case with sequencing the FKRP gene, which is one of the genes known to cause dystroglycanopathy, found heterozygous mutations which confirmed the diagnosis in these girls of limb-girdle muscular dystrophy type 2I. And at age 3, they're able to run, play, do ballet class, they have normal language and learning, and a normal brain MRI. So the learning points here, there are things we don't understand. In the last 2 cases that I showed you, both of those, or all 3 of those girls, had acute decompensation in the setting of a viral illness. We've seen this a number of times, but we don't see it in other muscular dystrophies. Typically affects infants and young children, and it's one of those things that we just don't understand yet, but it is something that gives us a clue that we might be dealing with a dystroglycanopathy. And then the other point from this case is that of all the genes involved in the glycosylation of alpha-dystroglycan, FKRP mutations are the most common. And I mentioned a founder mutation in fukutin. FKRP also has a founder mutation, which is shown here on the screen, and 1 copy of that is found in almost all patients. So our next case is now a 26-year-old male. So you can see that I've sort of arranged these in a progression from more severe to less severe. He had excellent general health, normal development. He recalls now that when he was in 8th grade, his legs would get sore and tight after exercise. In 9th grade, and this continues to the present time, he would have reddish-brown urine associated with this muscle soreness and fatigue. I actually have one patient who told me that they thought throughout high school and college that they hadn't had a good workout unless their urine turned brown. That brown urine is a breakdown product of from the muscle, and so it's called myoglobinuria, where the kidneys are excreting breakdown products from the muscle. And it can be dangerous. We don't encourage people to exercise repeatedly to the point that they developed myoglobinuria. So he had red-brown urine, and they sent him to a kidney doctor who said the kidneys were fine, and he kept on doing this. At 17, he had worsening difficulty with keeping up with peers, more fatigue, and finally at some point CK was done. The initial CK was 52,000. I suspect that that was in the setting of exercise, and later came down to around 7,000, which is where it has stayed. When we examine him at age 26, he has entirely normal strength. So because he had this chronically elevated CK and myoglobinuria, we did a muscle biopsy on him. And again, on the left, you see the H&E, which shows mildly dystrophic pattern. And on the right are the immunostains. And this one's a little bit simpler. In this case, we used, so again, the first immunostaining column is the control. The second immunostaining column is the patient. The top layer is dystrophin staining, and that is normal in both the control and the patient. And then a stain for glycosylated alpha-dystroglycan is on the bottom panel, and you can see again in the patient that there is a patchy loss of glycosylation of alpha-dystroglycan. And he is a compound heterozygote for mutations in GMPPB. Now, this is not the first patient that I've presented to you with mutations in GMPPB. And in this table, I'm just comparing the two patients that I've presented here with GMPPB. The current one started having symptoms at age 17 years and is now 26, and the other was a girl who presented at age 7 months and is now 13. They both have GMPPB mutations. Maximum motor ability, our young man that I just presented was able to weight lift and be very active in sports. The young girl who I presented earlier is able to sit and crawl. The young man has completely normal intelligence, whereas the girl that I presented is nonverbal. And both of them have GMPPB mutations. So the learning point from these cases is that the same gene can cause a wide range of phenotypes, and that you can't reliably look at the patient and predict what the gene is going to be. So once you're in the realm of a dystroglycanopathy, we're not very good at picking which of the dystroglycanopathies is going to be the one affected. And this is our final case study. This is a patient that I saw many years ago, but it is instructive. So when he was 2.5 years old, he was first seen, and he had started walking at 21 months. So most children start walking at about 12 months. Most children with Duchenne muscular dystrophy start walking at about 16 to 17 months. He had now lost walking at 2.5 months and seemed weaker to his mother. He had calf hypertrophy. His CK was about 4,000. And his muscle biopsy, this was in the early 1970s, just showed that he had muscular dystrophy. So young boy, high CK, muscular dystrophy, calf hypertrophy, the diagnosis with Duchenne muscular dystrophy. He went into a wheelchair at age 9, consistent with Duchenne muscular dystrophy prior to the steroid era. And his sisters had genetic counseling, and they were told that this is an X-linked disorder. They had a 50-50 chance of having an affected male if they had a male child, and they both elected not to have any children. When I first met him, he was quite a bit older. He was 22 years old. He had graduated from college in electrical engineering. He was in a wheelchair, but other than that, seemed quite healthy. So this wasn't feeling to me like a typical Duchenne muscular dystrophy at the time. He had no old muscle available, and he was very much not interested in undergoing a second biopsy, and at this point he was quite atrophic, and I'm not sure we would have been able to find muscle to biopsy. So at the time that I met him, we now had the availability of genetic testing. Most of you listening to this won't remember when we didn't have genetic testing, but once upon a time we couldn't do these things. So we looked for a mutation in dystrophin, which you understand is how we would go about making a diagnosis of Duchenne muscular dystrophy, and that was entirely normal. So then we went on and said maybe this is a dystroglycanopathy, looked at FKRP, which I mentioned previously, and he is heterozygous for the common mutation and then an alternative mutation. So he has LGMD2I, which is autosomal recessive, and totally revised the genetic counseling provided to his sisters. This is a very low chance that they would have a affected child unless they married somebody in the family. The population-based incidence of FKRP mutations is less than 1 in 300. And at least one of the sisters elected then to go ahead and have children. So the teaching point from this case is that making the correct diagnosis matters. And sometimes when I talk to students or when we talk to an insurance company, they say, you know it's limb-girdle muscular dystrophy, we don't have any specific treatments, why do you want to make a diagnosis? And I think this case illustrates part of the reason that it's really important to make a diagnosis. And then the other thing that to take home from this case is that there is a lot of overlap in the clinical features between different kinds of muscular dystrophies. When a young boy walks in the clinic and has calf hypertrophy and an elevated CK and proximal muscle weakness, I don't know for sure that he has Duchenne muscular dystrophy. It could be a form of limb-girdle muscular dystrophy, and I need to do the testing to make the diagnosis. So to sort of summarize what I've gone over in the last two talks, when do you consider a dystroglycanopathy? If you have a profoundly weak infant with elevated CK with or without brain malformation. If you have an adult or a child with a limb-girdle pattern weakness that's not Duchenne or Becker. If you have a child or adult with myoglobinuria, this brown-colored urine with exercise, muscle pain, and persistently elevated CK even when they haven't just worked out. And then particularly if you have a young child who develops profound weakness and an elevated CK that doesn't resolve after a viral illness. The diagnostic approach, we always start with the CK, which is virtually always more than 5 times normal. If it's a young child who has developmental abnormalities, you can consider doing an MRI of the brain and think about whether to consult the ophthalmologist to do a good eye exam. We have a research-based skin biopsy test that we do at the University of Iowa that's a complementation assay in which we grow the skin in tissue culture, document that there is hypoglycosylation on the skin, and then introduce each of the known dystroglycanopathy genes to see if we can restore glycosylation. That can be helpful in either confirming a suspected diagnosis or in directing you to what gene is most likely. And then either start with genetic testing or start with a muscle biopsy. I think most of us would at this point start with genetic testing if you have a strong reason to suspect a dystroglycanopathy. The management is currently nonspecific. There is no specific treatment, so the management is going to be similar to what we do for other kinds of muscular dystrophy. These individuals are at risk for cardiomyopathy, so we will do monitoring for a cardiomyopathy. They are at risk for respiratory insufficiency, so we'll monitor for that. We'll monitor for scoliosis or curvature of the spine. These patients get physical therapy and education and stretching. They get educational support if they have brain involvement, and then genetic counseling for an autosomal recessive disease. So in the first half of this mini lecture series, I talked about the muscular dystrophies, which are inherited disorders with progressive muscle weakness due to degeneration and regeneration. I talked about the fact that there are lots of different kinds of muscular dystrophies with very different inheritance patterns, genetic causes, pathophysiology, and clinical manifestations. Among the dystroglycanopathies, which is one subset of the muscular dystrophies that is characterized by hypoglycosylation of alpha-dystroglycan, there are at least 18 different genes involved in glycosylating alpha-dystroglycan, and mutations in any of these genes can cause muscular dystrophy and basically can cause the full range of clinical symptoms, most likely. So when I have a patient, I can't predict which of those genes is going to be abnormal. These symptoms can range from being a very severely affected child with brain malformation, eye malformation, and muscular dystrophy and weakness to a virtually asymptomatic adult. So with that, I'd like to thank you for your attention. The picture here is from a family conference for individuals and their families with dystroglycanopathies that we hold annually. And I'm very grateful to the many patients and their parents and other family members who have shared their experiences with me and have taught me an enormous amount about this group of diseases. I also want to acknowledge the NIH, the Iowa Wellstone Fellow Center, the colleagues who referred the patients, and then my colleagues at the University of Iowa who are listed there. Thank you very much for your attention.